The Whipple procedure, or pancreaticoduodenectomy, is a fairly complex surgery that can take anywhere from 5 to 8 hours to perform. It's typically done in the surgery suites, which is on the 3rd floor here at Roswell Park, and patients are in the hospital approximately 9 days after surgery, but that can vary anywhere from 7 days to as many as a few weeks, depending on how the recovery goes, and also depending on how you're doing prior to the surgery. If you're in very, very good health, young and very active versus maybe older with a number of medical problems, that can have a large impact on the length of and how you recover. What I'd like to do is just talk about the actual procedure and describe what the surgery entails. So I'd like, with the help of this diagram, I'd like to walk you through what a Whipple procedure actually is. Now, in this example, we're talking about a tumor in the head of the pancreas. This is the pancreas, the tail of the pancreas, the neck and body of the pancreas, and the head of the pancreas. And recall, though, however, that you can have other types of cancers that we would do a Whipple procedure for, but in essence, the operation is the same, whichever type of cancer we're dealing with. So in a Whipple procedure, the head of the pancreas is removed, and this is the head here, as well as the first part of the small intestine called the duodenum. The reason we need to do that is because there are lymph glands in this area, and those have to be removed as part of the surgery. What the pathologist will do is look at those lymph glands to see if the tumor has spread there, because these tumors can spread to the lymph glands, and that's very important in us determining what kind of therapy you might need after surgery, be it chemotherapy or radiation therapy. So the Whipple procedure involves, the classic Whipple procedure involves removing the lower part of the stomach, the first 10 inches of the small intestine, the head of the pancreas, and all the lymph nodes around it. We also come across the bile duct, which carries the yellow bile from the liver. So all the bile that's produced by the liver comes down, is stored in the gallbladder, goes through the head of the pancreas, and you'll see here if there's a tumor that can cause blockage of the bile duct. The gallbladder is removed with the Whipple procedure as well. So what you see here is the head of the pancreas, the first part of the intestine, the lower bile duct, the gallbladder are all removed with the Whipple procedure. So, and this part of the surgery generally takes about 3 or 4 hours. It can be shorter if it's simpler, but it can also be more complicated if the tumor involves some of the major blood vessels that run behind the head of the pancreas, and we'll talk about that in more detail if your particular situation warrants that. But this would be considered the standard Whipple procedure. There is a modification of the Whipple procedure where we do not remove the lower part of the stomach. That's called a modified Whipple procedure, and that may be done in certain circumstances where it's appropriate. The first part of the operation involves removal of the tumor, and this is what it would look like after we've removed the tumor, the head of the pancreas, the lower bile duct. So what you have is you have the tail of the pancreas, which is about 50% of the pancreas, and this is the part of the pancreas that does make insulin. It also makes digestive juice. So many patients can do just fine just with the tail of the pancreas. Some will need replacement with pancreatic enzymes. Some may need some insulin replacement if they already have some mild diabetes. But many patients, about half, will do fine with just the tail of the pancreas. The stomach is here and the bile duct is here. So you'll see here for the second part of the operation, that involves hooking back up, basic plumbing, so to speak, to hook the pancreas, the stomach, and the bile duct back to the intestines so that you can eat normally. So what I'm going to do is show you the second part of the Whipple operation, or the reconstruction part. So I'm going to redraw it to help walk us through this. So here's the pancreas, and then the liver here, and the bile duct. And if you'll notice here, the intestine, we're going to move forward because we have to fill, there's a gap there. So we're going to move this intestine forward, and what's going to happen here is we're going to sew the pancreas to the intestine. Now the pancreas is generally a soft gland, so this is generally the most difficult part of the operation. Oftentimes we'll be wearing magnifying glasses because this little pancreatic duct may be only a few millimeters in size. And then the next thing we do is hook up the bile duct, which is where the yellow bile comes down from the liver, and then we loop it around over the pancreas like so and hook up the stomach. So what you'll see here is that the pancreatic juice, which helps you digest your food, as well as the bile juice, which helps you digest fatty foods, these juices are going to go into the intestine, okay? Then they're going to come around here, and the food is going to be in the stomach. That's going to come here, and the digestive juices in the food are going to mix together, so digestion will occur normally after this point. So we're basically recreating the normal physiology where you have your digestive juices and the bile juice mixing with the food so that you can eat and have a normal digestive function. Now, there's a couple of things I want to mention here. First of all, in terms of the potential problems that can happen after surgery. Now, the Whipple procedure is a complex surgery. The surgery can take, as I said, anywhere from 6 to 8 hours. And this is generally the second part of the procedure. But one of the most problem areas we have, because the pancreas is very soft and you have to sew it to the intestine, we can get leaks from this area. About 15 to 20% of the time, we will get a leak from this area. And what we do at the time of surgery is we put a drain in that comes out of your right side. There's generally a single drain hooked up to a little bulb, a little plastic bulb. And that drain, we lay right next to the pancreas. So if and that little drain has holes in it, so if there's a leak of pancreatic juice, the drain will pick it up and it'll carry it out to the bulb. Now, if that happens, many times that can be managed with just the drain and modifying your diet, putting you on a low-fat diet. And as I said, about 9 out of 10 times this will heal on its own. But every so often it won't. And we may have to do some other intervention, such as the radiologist putting in a drain through the skin under ultrasound or CT guidance because there's a fluid collection. What may happen here is that you can get a pocket of fluid that the drain doesn't drain, and the radiologist will put a little drain in it. And then occasionally we will have to take patients back to surgery. Fortunately, it's fairly low. Less than about 5 to 10% of the time, someone may have to go back to surgery to clean up an infection that occurs in this area. So the big problem that we have with the surgery is pancreatic leak. Less or so, it would be a leak from this area. That's relatively rare. The other common problem that we'll see in as many as 20 to 25% of patients is what's called delayed gastric emptying. Delayed gastric emptying is when you eat your food and the food just sits in your stomach for a period of time. It doesn't want to go through, and so for an hour or two after you eat, you'll feel full and uncomfortable. That's called delayed gastric emptying. Rarely, but I need to mention it, is that you can have something called dumping, where you eat the food and it goes down too fast. So there are changes in your digestive system that occur with this surgery. Fortunately, most of those are short-lived. Delayed gastric emptying usually resolves in a few days to a few weeks after surgery, and we can make some modifications of the diet to help with those symptoms. The other thing I will mention about the tail of the pancreas does make insulin, and so patients who are diabetic may find that their sugars are a little harder to control after the surgery. They may need more insulin, or if they're on pills, may need some insulin. Patients who are not diabetic are very unlikely to need insulin after this surgery. Generally, what I'll say is that if you have some pre-existing diabetes, or you're predisposed to diabetes because you have a family history, having the Whipple procedure may lead to earlier onset of problems with elevated blood sugar. So I think that's something that needs to be mentioned. The other thing the pancreas does is makes pancreatic juice or enzymes. So about 40% of patients after the surgery will need pancreatic enzyme replacement. Those are pills that you take right before you eat a meal that helps you digest your food. The sign of that would be If your stools are very loose and you have diarrhea after the surgery, that may indicate that you need some pancreatic enzyme replacement. So about 40% of the patients will need enzyme replacement, and there will be patients that may need better sugar management after the Whipple procedure.